Thank you. Thank you, folks. So it's a profound honor to be here. Thank you for all of you for being here, for being so supportive of this work. It's an honor to be, representing my team at NYU. This is a group effort that goes into every aspect of this presentation that you'll see. So just a bit of background about me. So I'm originally Canadian. I was raised in Burlington, just outside of Toronto, went to school at Western for undergrad and grad school, and then ended up moving to do this type of work, the psilocybin for alcohol use disorder work at NYU. So I work with Michael Bogenschutz, with Dr. Steve Ross, and there's a little visual of the research team. So you'll see there, it's a pretty small team. This has evolved to be what feels like a family that's super passionate about this work and passionate about finding ways to alleviate suffering in the patient population that we're honored to work with. And we're also funded by the Hefter Research Institute. So before I go into, I'll be talking primarily about the main study that we're doing. It's a big study. It's a phase 2 treatment study using psilocybin for alcohol use disorder. But before I go into that, I'm just going to kind of cover the history. It's important, I think, to honor the lineage of the medicine itself, and then to talk about the research that kind of set this work into place. So going back through research, what I noticed when I first was involved in the psychedelic community and from a research perspective is that a lot of the timelines in the history is presented from the perspective of the U.S. and sometimes the Canadians don't even get enough credit when we're doing talks in the States. So there's a lot of focus on the American history, and I think panning out even a bit further in terms of the timeline, it's important to go back as far as the history of this particular medicine goes in human history. So the modern use is very, very small, and it's very new, and it's in some ways in its infancy when it's housed in Western medicine in comparison to the wisdom traditions that have carried this medicine for thousands of years. So I want to start there and then do the switch into more modern history. So we're talking about psilocybin here. This is the active ingredient in hallucinogenic mushrooms. And so I'll trace the history back. There's evidence from petroglyphs, from carvings in caves that date back to 9,000 BC. And obviously, those are found in Africa, in areas of Spain, through Mesoamerica. But there's history there that is suggesting that hallucinogenic mushrooms were involved in some capacity in the human experience, and more recently with the Mesoamerican traditions used for healing practices. So that brings us, to this person. So honoring Maria Sabina. This is a Maztec healer. She was a curandera, a very powerful woman who used psilocybin-containing mushrooms for healing purposes in her tradition. And so the reason that I'm showcasing her is because this point of time in history marks the transition for psychedelic mushrooms, for psilocybin as a compound, from old world, from the ancient tradition into a more modern use. Okay, so the way that she used in the Maztec tradition is very different from the way that we use psilocybin in the lab, in the hospital right now, and I'll go through that later, but I want to showcase how it's used in ceremony, in particular the ceremonies that she was facilitating. And so the intention was to facilitate healing, and she was quoted as saying to use the substances, to use the plant medicine to reveal unseen parts of self. So the ceremonies took place at night. They involved either the individual who was seeking a ceremony, seeking healing, or sometimes they involved the individual's family or the system of relationships that hold that person in place. So sometimes they're individual ceremonies, sometimes they're groups of individuals together. And the way that she would work with the plant is that she would take the mushroom in addition to the individuals taking the plant. And so the orientation is very different from Western use, because the intention behind the shaman or the healer taking the plant is to open their perception to be able to perceive the root cause of the issues that are facing that individual, and to also perceive the solutions that can be transmitted either through language, through song, through prayer, however it is received through the healer. That cure is delivered through the ceremony to the individual. So it's speaking to the sickness, whereas with our orientation, it's very different. And the reason I'm highlighting this is just so that we make a distinction between the shaman and the healer and the psychotherapist, because they're two very different positions. The psychotherapist is listening, the psychotherapist is meeting and receiving the person, but is not working to intuit or to perceive the solution to this individual's problem. So it's very different. I'm not going to comment on, better or worse. It's just different. But it's important to acknowledge the lineage that comes before the use that we do currently. So in 1957, a man by the name of Gordon Watson, so he was an author, he was a banker, he was interested in mushrooms. He traveled to Mexico and he was involved in a ceremony with Maria Sabina. So she held a ceremony for him and for his partner. And after he was involved in the ceremony, he returned to the US with psilocybin as a compound, introduced it to the West, and also wrote about his experience. So it was one of the first times in history when this medicine arrived in North America. And from that point, we see a transition into more modern use, and I'll go into that in a little more detail. So we're seeing modern use in a clinical context, we're seeing modern use in the recreational context, and in medical research, which is what I'm a part of right now. So going into a little more detail about Western use. So initially, this medicine, psilocybin aside, let's focus on LSD. So there's some overlap in the timeline, and I'll focus back on psilocybin because it's the molecule that we're using. But the history, the social stigma of psychedelics is far more tied to LSD than it is to psilocybin. So initially, throughout the 50s and the 60s, LSD was used for alcohol treatment. It was used clinically here in Canada. The roots are actually Canadian in treatment in Saskatchewan, and I'll speak more about that in a moment. But there was research and clinical use in Europe, different parts of North America. You'll hear names like Stan Grof coming up because he was doing research at that point for a number of things. So end-of-life anxiety was used very commonly for pain, for OCD. So clinically, this medicine was used. Some estimates have reported over 40,000 people worldwide receiving LSD for a treatment of a number of different disorders. So at that point, it was used primarily by therapists, held in a clinical context, and that led into more recreational use. So at a time, that was politically complex, around the time of the Vietnam War. Mark chatted a little bit about this era this morning. There was that recreational use that presented promise in some ways and also presented some risks when it was used in unsafe settings. So though the risks were very much amplified, there was a lot of fear associated with the toxicity, which doesn't have much evidence to back it. It led ultimately in these drugs being criminalized. And in the States, psychedelics were criminalized, or there was Schedule I, which means that these are the most dangerous drugs, the most addictive, and that these drugs have no medical or therapeutic potential whatsoever. In Canada, they were Schedule III, so a little bit less risky, potential medical benefit to them, but Canada did follow suit with the criminalization that happened in America. So then that leads us to, that was around 1971 for the American criminalization. That leads us to this period of dormancy for the most part. There was recreational use, obviously, but clinical research was not happening during the period from the 70s to the early 90s. Clinical use, obviously not happening above ground. So then in the 1990s is when the resurgence kind of started, and it links back to someone named Rick Strassman. So he started doing studies at the University of New Mexico with DMT, and he was not using this in a clinical population. He was just doing dosing sessions where he would inject individuals with DMT in the medical center, and they were healthy, normal individuals, so not people who were seeking healing of any type per se. So that kind of opened the door. He also did some psilocybin studies that weren't published, but he started working with these substances in the context of a university, in the context of a medical center. And from that point on, there's been a slow resurgence that's taking off, quite more so in the last couple of years. But we see, the psilocybin for anxiety and depression in cancer patient studies that have come out of our group at NYU, UCLA, the Hopkins folks, work on depression at Imperial College, psilocybin for alcohol use disorder, which is what I'll go through with you right now. All of the MDMA work that's happening, here and in the States. And then there's some research in more non-healing focused studies, so doing the neuroimaging work out in Europe, and doing some creativities. There's some microdosing talk that's starting, so some non-clinical indications. But it's interesting to note that the majority of these studies have had a healing focus to them. So right now we're looking at these experiences being housed in the context of medicine, of the healing profession, which has potential to revamp how we consider healing from a medical and a Western and allopathic perspective. So starting to hone in on the use of psychedelics for alcohol dependence. This is setting the foundation for the phase 2 clinical trial that we're doing right now. So the base is obviously in Canada, which we've heard this morning, but 2 individuals, Abram Hoffer and Humphrey Osmond, were initially using or looking to use mescaline as a model of schizophrenia. And so they started using that, found that mescaline was very hard to get a hold of at the time. A few years before, LSD was synthesized and it was being distributed to mental health professionals through Sandoz Pharmaceutical Company. So LSD was easier, to get a hold of, to work with, to synthesize. So these 2 decided to see whether it would be an adequate model for schizophrenia, and it was not. And so in terms of their use clinically, they started noticing that it was leading to symptoms that looked like the delirium tremens. And so the DTs are a syndrome or a collection of symptoms that come up when individuals are detoxing or going through alcohol withdrawal. So for the more severe withdrawal cases, people can get, severe tremor, sweating, flushing. It can get to the point of having severe hallucinations and having confusion, paranoia, and at the very extreme end, it can be fatal. So they thought that high doses of LSD were modeling the DTs, and they thought that having alcoholics experience that through this kind of synthesized way would scare them into not drinking anymore. So in that context, with that perspective, LSD was used clinically, and they started to see that the changes were beyond just a set of symptoms. There were lasting changes in perception, lasting changes in perception of self, in beliefs, and in drinking. So it showed significant clinical promise at that time, though the research, to provide evidence was very minimal, and we'll talk about that in the next slide. So to the Krebs and Johansson review. So these 2 did that review that Mark talked about this morning as well. I'll go into it in just a little more detail. Because it really lays the foundation for the pilot trial. There wasn't much between these studies and the pilot study for psilocybin for alcohol dependence that happened in 2015. So the 6 randomized control trials happened in the late 1960s, early 1970s, and they varied in so many different ways. So females were grossly underrepresented. It was mostly male inpatients who had alcohol use disorder. They received single dosing sessions of LSD. For some folks, they did not give them any preparation on what drug they would be receiving. They did not give them any information on what LSD was. For other studies, they did intense preparation, had them doing homework to learn about what LSD was. They were giving them lectures. So the preparation is very different across these 6 trials. The settings varied significantly. Some used a living room-like setting, which is very similar to what we use now, actually. Others, were injecting LSD while people were laying in their hospital bed. So very different in terms of setting, very different in terms of the support, integration, and the type of therapy that was used in the protocols varied also. So some of these studies were using individualized therapy, so one person plus a therapy team. Others were using group settings, and some used a combination of both. Some didn't even have any sort of therapeutic process. But even with all of that variation, when all of the results from this were pooled together, the outcomes favor LSD in terms of drinking. So though these are not scientifically rigorous studies, there's evidence to suggest that, you know, the use of psychedelics, in this case LSD, for treating alcohol use disorder, that there's some validity there, there's some something there to explore further in a more controlled kind of context. And so that's where the roots of this kind of work fall into place. So I'll start talking about Michael's psilocybin for alcohol use disorder pilot. So this was a feasibility, a proof of concept study that was designed, you know, to see whether it would be feasible to use psychedelics to treat alcohol dependence. And you'll notice we're switching from those earlier research studies that were working with LSD, we're switching to psilocybin right now. And that comes from the fact that psilocybin is easier to work with clinically. So the course of action in terms of the time to peak effects and the time to the return to baseline consciousness, it's just shorter. It's about 6 hours in comparison to LSD, which can last, you know, 13, 14 hours for some folks. So in terms of using this in a medical setting, using it as a model for clinical use, psilocybin just makes more sense from that perspective. In terms of the intensity of dose, some of the folks, you know, in this trial, in our trial right now, are hallucinogen naive. And so starting them with LSD, which sometimes can be overwhelming for individuals, maybe too much. So there was a push to start with psilocybin. It also didn't have the culturally negative associations with it that LSD and acid does. So it made more sense to work with psilocybin for those reasons. And so the objective of this work was to demonstrate feasibility and to pilot a psychosocial package or platform to use in addition to the dosing session. So the design of the study is single group, so no placebo group with this study. There's 10 individuals who went through it, and they underwent 12 weeks of weekly psychosocial treatment. And within those 12 weeks, at week 4 and at week 8, they received the study medication. So they had their dosing session with psilocybin. And so this is the outcome, two ways that we conceptualize the outcome. So one is % of drinking days and one is % of heavy drinking days. And so you can see the whole trajectory moving from the baseline point, so pre any sort of treatment, so pre-therapy, pre-medication, through to the last follow-up, which in this study was 36 weeks. And notice the difference. It's interesting to see that first psilocybin treatment session is happening 4 weeks into the study. There's already a reduction in the amount that these individuals are drinking. So there's something about that, the therapeutic process, maybe the expectation of receiving a psychedelic, you know, that the spirit of the plant, that may come into play here. We're not sure, but it's interesting to think about all of these possibilities. But something's happening to drive that, the amount of their drinking down. And then at week 4, they receive their first psilocybin treatment, and you can see that there's a steeper slope. So drinking did decrease for this group of 10. Remember, it's 10 people. And then the follow-up right to week 36, we still see the reductions in drinking outcomes persisting. Okay, so in addition to drinking, things like mood, anxiety, self-efficacy, self-compassion are also measured, and so those correlate with the intensity of the experience as well, which is interesting to note. So switching into the study that we're currently running at NYU. So this is run at a major hospital, Bellevue Hospital, downtown New York. It's a psychiatric hospital. We do everything there, but it really has a reputation around psychiatric care. So the comparison is between psilocybin-treated individuals to the placebo group who receives diphenhydramine. Diphenhydramine is Benadryl, and we give it to individuals at a higher dose than you would normally take over the counter because it's considered to be an active placebo. So at these doses, it can have mind-altering effects. The effects of both of the medication, they differ from person to person, so there's no way to really predict or to kind of lump them into what usually happens, but for some folks, there can be an alteration, especially for the folks who don't have a reference point for what a psychedelic feels like. There's been some patients who've gone through the study who, you know, the therapy team may think or may guess that they received one drug and the individual thinks that they received a different drug. So it's not always as obvious Obviously, everyone in the study is blinded. We have an independent person who holds the blind, the pharmacist. So everyone who's around the patients themselves are blinded to what the medication actually is. And so, like I said, we assess the characteristics of the dosing experience through the integration process and their effect on the drinking outcomes. We have some measures of intensity, which, the interesting thing about this study is because it's ongoing, presentations like this give little opportunity to present data. Because I'm blinded, I can't really present you folks with data. We did a little peek, which I'll show you, but for the most part, what I'm able to show you at this point is really the things that we've observed just by being in the room with some of the patients. And so I'll go through some case studies rather than focusing too heavily on data. So far, 54 individuals have been randomized, so have received study medication. 26 have completed the entire protocol. And we're looking to dose 100 people at minimum. So it's a 5-year study. There's 2 years left. And at this point, we're dosing folks at a rate of about 2 medication sessions per week, in addition to all of the therapy. So it's moving. So let's go through study design. This is a very complicated figure, but it's a complicated protocol. So I'll take you through it. We're looking at a year process in this study. So folks come in, and if I draw your attention to the column that says weeks, at week 0, they are starting the treatment process. And there's 2 types of treatment. So there's the therapy and there's the medication. And so from week 0, they start coming in every single week for an hour to 2 hour long therapy session. And then right at week 4 is when the randomization occurs. So they're randomized to either receive psilocybin or they're randomized to receive the diphenhydramine. And then they stay in that randomization tract through to the end of the study, okay? And then the therapy visits aren't written here, but just at every time that you see a week indicated, know that there's a therapy session. So for the first 12 weeks, it's therapy every single week. It's fairly intense for the first 12 weeks, 2 dosings plus 12 therapy sessions. And then they move into follow-up. So we're not treating them after week 12. They're going to live their life, and then they come back, and we do check-ins with them at week 24 and at week 36. At week 36, there's this optional 3rd dosing session that they're invited to participate in. It comes with additional preparatory and integration therapy sessions. But the unique thing about this session is that it's open label, so there's no chance of receiving the placebo. It's a psilocybin-only session. And it's interesting to be exposed to those because there's no pressure to hold the blind. There is no blind. Everyone is getting open label psilocybin, so there's a freer flow of conversation about the study drug, about the effects that happens. So it almost models clinical use in, I think, a more accurate way. So yeah, then they're followed up until week 54. So they're with us for just over a year. So I want to give a little more information about the 2 styles of therapy that we use. So we follow the model of the traditional model, which is a male-female dyad for the most part. For some, we'll do female-female pairs. Depending on really what the participant is comfortable with, it's an open conversation about alignment with an appropriate team. I think that's the most important thing. And the 2 styles, the psychosocial is divided into 2 styles. So one therapist is running what's called meta sessions, and so that's based in motivational interviewing style therapy. It's non-directive. The focus in those sessions is on, what is your relationship to alcohol like right now? What do you want that relationship to look like, and how do we make those 2 closer in your reality? So we're not a team that's pushing abstinence in any way, though from a research perspective, the less drinking, the better the outcome. But clinically, it's about the person's goals in relation to their drinking. So if they want to be abstinent, we support that. If they want to just reduce the amount that they're drinking, we support that too, though we do have a tendency to invite people to take a break from drinking if they're able to do it for 9 weeks in the trial, and then to decide whether alcohol has a place in their life as they move forward. And people seem to be open to that. If they're not, then that's fine too. We don't exclude anyone. And so the meta sessions have kind of a holistic approach. So the orientation is just to meet the person where they're at. So the focus is on bringing it back to alcohol, but we move into areas of wellness that, you know, focus on nutrition, that focus on the mind-body connection, that focus on wellness and how that manifests in each individual's journey. Okay. And then there's the psychedelic style of therapy, and this is less therapy. This is more psychedelic preparation, support, and integration. And so this is where the other therapists would jump in and take the lead. So both members of the team are present at every single session, just to build that rapport. So when the individual goes in for their session, the team is bonded, so that they can feel safe, they can feel like they can express themselves fully. With the psychedelic-focused therapy, it's even less directive than the non-directive meta approach. It's about doing a life review. So one of the preparatory sessions, we spend a couple of hours going through, you know, I like to say, what made you who you are at this point in your life? Go back as far as you need to go. Go back into, you know, your family history. Take us through whatever you think made you you. And the purpose of that is to have them self-reflect. Some people have never told their life story to others or to themselves. Some people, you know, have a lot of trauma and a lot of trigger incidents that it's helpful to talk about if they feel comfortable with it, so that during the dosing day, if something comes up and they're at an intensity level beyond language, we don't have to talk about it. We can be with them because we have already heard it through their life review. It also gives them a chance to get comfortable, you know, with us. So the life review is a big component of the preparation. And then there's a lot of discussion about fears, anxieties, what the medicine may feel like, what's happened for other participants. So we don't really talk too much about that, but there's a, you know, a bit of chat about what could happen. Yeah, and then there's some discussion on how to, you know, self-regulate if any sort of anxiety comes up, if anxious thought loops start coming up. We teach them some grounding techniques, some meditation, just ways to support themselves and to familiarize them with ways that we may support them during the session. So it's also a discussion about what they're comfortable with. So that's a time to talk about, you know, are you comfortable with touch? Does that not work for you? Just to know how we can best support each individual. The therapy, everything about this study is really designed to support each person in their own unfolding. And so it means meeting them where they are and having an open dialogue about what their needs are and how we as a team can support them. And then the other style of treatment is the medication. So we dose by weight. So we start at 25 milligrams per 70 kilograms, and then there's an option, so that's for dose 1. So based on the intensity of their experience in that dosing session, and based on their personal preference. You know, if they think that was enough, then that's enough. It's their decision in terms of what their next dose is, if they opt in for the next dose. So most do. Then for Med 2, there's the opportunity to either hold the medication at the same dose as Med 1, or to increase it, either to 30 or to 40 milligrams per 70 kilo, which is a big dose. And then if they're randomized to the Benadryl group, and they decide to do an increase, the increase happens for Benadryl as well. So we're talking about these dose increases more in relation to the intensity of the experience than to what drug did you receive, because we don't know. And so we do the administration in an oral capsule, and I'll talk more about that right now. So I'll take you through what a medication session looks like. We're using the traditional, this is kind of the traditional setting that was used back before these drugs were made illegal. So, you know, what Stan Groff was using in his experiments, we pull from that because it has some evidence clinically to support that it was useful. So there's a lot of attention focused on set and setting. Though they're in a major hospital with multiple layers of medical support, this is happening in a medically supported area. The dosing room itself looks like a living room. You wouldn't even know you're in a hospital aside from the medical monitoring and the emergency support meds that are available in the room. But at surface, it really just looks like it is just a comfortable space to take this inward movement. And so we support a non-directive approach, so there's no talk therapy during the session. For most participants, just thinking through, for the high intensity doses, it's often the case that they move beyond the realm of being able to talk. So people are moving inward, and we're not in a position to pull them out of that. So the goal is really to have them experience the experience as fully as possible and to find the answers that they may be seeking within themselves, not through conversation in the room. So we start the day. They usually come in around 8 o'clock. We do some intake, make sure everyone's healthy and stable, and then around 9 o'clock we do the dosing. So it starts with an intention setting ceremony, just to bond the group. We all kind of come together, the two therapists and the participant, and we focus a lot on the intention. So you're seeing and hearing, me and others talk about the use of, it's psilocybin or psychedelics in particular, for a number of different indications. So we see, the smoking cessation studies as having some promising results, and we see the alcoholism work, but really the intention, the focus of the intention is an important component of this, and that may be what's differentiating the treatment effects in each study. So we encourage people to spend time reflecting and preparing on why they're doing this and what they're hoping to receive, and then as soon as they set that intention, we encourage them to, not turn it into an expectation, which can be a challenging thing to do, but there's lessons in all aspects of this work. So we start with the ceremony, and then they receive the study medication in an oral capsule. So that's around 9 o'clock. And then they're given a set of eye shades. They're given headphones, and there's a preset music playlist that they lay down and listen to for the entirety of the dosing day. So we're in there, as guides providing medical monitoring. There's always a physician in the room monitoring blood pressure, though the medical risks are very, very low. It's comforting. From what I've heard, it's comforting for folks to have a medical practitioner in the space, so they don't have to worry about their body. It's kind of like, more often than not, it's Michael sitting there and saying, like, I've got your body, you go wherever it is that you need to go, and so you don't have to worry about your physical form. We've got that, unless there's some information in the body that's of use to you. So yeah, the medical monitoring happens, but the objective, as I said, is an internal orientation, so that they can take the movements that they need to do. They can open their inner senses, they can move inward and understand how to bring themselves into balance. So the goal here, is to have the safe container, and we encourage full expression. So we say to them, if you need to scream, if you need to cry, if you need to laugh, whatever it is that you need to do, as long as you don't harm yourself or harm us, you're free to do it. This is a completely non-judgmental space. And we do see that. We see a full range of expressions. And then, some people we see absolutely no expression, which is amazing as well. So everyone is free to do what it is that they need to do. And then the support is offered if the need is expressed. So we offer support through physical touch if they're comfortable with that. So really the focus is on grounding them, bringing them into a sense of self. And sometimes that grounding movement, just a simple touch on the body, can actually send them, deeper inward or deeper outward, which, depending on whichever way they tend to move. Grounding can actually provide a really solid foundation for deeper movements. So that's kind of how a med day looks. Around 4 or 5 o'clock, they usually flip up the eye shades and start engaging a little bit of conversation. But the goal is, to be with it as long as you can. By 5 o'clock, we're doing the mental status exam, and they're going home to rest. Okay, so it's designed in some ways to be effective in an outpatient clinical setting, which is interesting. So this is our dosing room. Here we did a little photo shoot, but you can see the therapist we're sitting with the person, they're having their own experience, we're there if they need support, and it's interesting, some people say, oh, I don't know how that would be to, be taking psychedelics, a high dose, and to have 2 people staring at me the whole time, And so I asked, the last couple folks that I've worked with, I said, what does it feel like to have us be in the room with you? Like, do you feel like you're being watched? What is that like for you? And they were like, no, I'm so happy to have you guys there. And, I know you're not watching me the whole time. We're doing whatever it is that we're doing, reading a book, but just to have you there to know that I'm safe is really important. And I was surprised to hear that in some level. So, it doesn't seem to be an issue that's come up. And by the time they're going in, they've spent a lot of time with us, so they seem to be quite comfortable with us. So moving into more qualitative observation. So this is what we've seen in some case studies, and what we've seen, just recent observations over the course of the last couple of weeks. There's some stuff that's come up that I think is really interesting. And this is kind of where I take off, the clinical researcher hat, and I just kind of go with we're seeing some fairly unusual and extraordinary things happening, and I think it's important to share that too. So going into the qualitative content that's coming up, so this is a mapping of some of the things that we see. So this is based off of, masters in Houston. They wrote the book, The Varieties of Psychedelic Experiences, which does a really beautiful job based on a number of case reports that they observed and that they were involved with. It does a beautiful job of categorizing the different dimensions that people can encounter with a classic hallucinogen. And so I've added a little to their dimensions, just based on things that we've observed. Though in no way is this a complete picture, in no way is this evidence of what reality is. This is observations based on what people have experienced and what they've reported to us. So we, in a lot of ways, as a research team, are students of this medicine. So we are learning and we are observing and watching the unfolding as it happens. So that position of humility, I think, is really important and is understated sometimes. So there's folks who have these body level, sensory level experiences and content that comes up. You see, the visual hallucinations, auditory hallucinations. Sometimes, what we've seen is energetic movements can happen throughout the body. People can experience somatic pain that they can actually work with in their sessions to understand, experiences that may be mapped onto the body. There's also the realm of autobiographical content, so the psychological stuff that comes up, what has come up in my life and what didn't I process, what memories may I have not examined fully or felt fully or experienced fully. So self-examination, examination of relationships, examination of who they are, and sometimes people have, the reliving and the remembering of certain traumas, of accidents, of surgeries. That's not uncommon. And then the fears can come up in this plane as well. So fears, the paranoia, which can all be useful. We're of the perspective that whatever comes up is coming up from within you. So accept it. And in the integration, we work with even the unpleasant states. So the preparation is focused on, even if it's unpleasant, you're in a safe space to observe it and to become curious about why it's coming up for you. What's the lesson within that? Look beyond the form and see if you can access the lesson. Here we go. And so then there's different types of experiences that almost have a tendency to move away from a very personalized sense of self. So into the archetypal, into mythical level narratives that apply to the individual that may not be specific to them in themselves, in this personality, if that makes sense. So archetypal, higher level stories that can connect individuals across, just across the human experience itself. We had one patient who actually relived, so she wasn't Jewish, had no family members who were involved in the Holocaust, but her dosing session was her reliving the suffering in concentration camps in World War II. And so she was a child, and she was moving through this narrative of experiencing profound suffering. And she said that taught her, that was the deepest point where she had experienced this profound level of human suffering. And her lesson in that was that her role in the world was to use her gift of humor to assist people who were experiencing suffering. So the lessons come through. Sometimes they're about the self, sometimes they're not about the specific individual. We've had people who perceive past lives, if that's within the realm of their perceptual reality. There's movement into other realms, movement beyond Earth. And there's communication with non-human entities, guides, spirit guides. And I think it's important to bring this stuff up as someone who has a scientific background. We're seeing some very unusual and traditionally non-scientific events and observations and experiences that it's important to be completely transparent about all of the things that are coming up because they're important and they have a role in the healing narrative, absolutely. Then we move into more states of communion with the divine, with God, so that states of rapture, states of bliss where the separate self is retained but it's in communion with something higher. Death experiences, birth experiences are possible, and then there's the unitive, so the non-self states, which can be challenging to describe. I won't go into too much detail, but just the state of absolute beingness has been reported by some individuals in the study. So I'm going to take you through 3 case studies in some detail. So these are 3 individuals who, and remember, we're still blinded, so we haven't found out what medicine they're taking. I'm basing the case reports on the intensity of their experience and on their drinking outcomes, okay? So the first case, we'll call him Peter. So this is a 25-year-old man who was living with his parents. He worked on Wall Street, very stressful job in finance, was a binge drinker, frequent blackouts. He actually met criteria for alcoholism at 14 years old. Extensive treatment history from that point, and nothing had really worked for him. Family was around, family was supportive of the study, of his process, and so it's interesting, his pattern of drinking is unusual to compare to the remainder of the participants, but at intake he was drinking, out of the 84 days, we do a drinking history, he was drinking for only 6 of those 84 days, but on each of those 6 days he was having an average of 22 drinks. So very heavy drinker, but not a regular drinker. When he would start drinking, he would drink as much as he could until he blacked out, usually. Yeah. So very little hallucinogen use. He had used MDMA previously, but none of the classic hallucinogens. And so he received 3 dosing sessions. So in his first dosing session, he said that was focused on perceiving the answers to all of life's questions that he had. So very information-based, insight-based type of experience. He also had, some moments of examining his anxiety, his fears, the pressure that he put on himself, and said that for the first time after that dosing session, he was able to reference a place of peace within himself that had been foreign to him up until that point. And that persisted through to the last time that we saw him, that referential point of inner peace. And after that first session, he stopped drinking. So he came in for his second session. His second session was very different. It was higher in intensity. He experienced his own death fully and then a rebirth, which was very intense, but after reflected on it and said that, it felt like a rite of passage for him. So a movement into adulthood. Remember, he's 25 at the time. And, he said that it was a movement into maturity in that second session. And so when he finished that second session, he actually came out with this urgency to serve humanity at a greater level. And he wasn't sure what that would look like. And we said, just see kind of where it opens and where it takes you. But there was this urgency to do service at a greater level, at a level beyond himself. So we didn't see him after week 12. He came back for that 3rd dosing session and said that at that point, during the follow-up, he was profoundly anxious in relation to his job. He said that, his intention for the 3rd dosing session was to deal with some of that anxiety, and that's exactly what happened. So he had a complete discharge of anxiety, so hours and hours of the release of anxiety. He said it was very painful and horrible, but not so much tied to narratives, so storylines were not there, but he said he had this discharge and had discarded to some degree that anxiety after the session. He also examined some of the darker aspects of fear, disappointment, regret, shame, and unworthiness. So it was the first 2 sessions were somewhat transpersonal, cosmic, whatever term makes the most sense in your language, but they were in a higher realm than the personality level, the emotional level, whereas that 3rd session brought him, into the emotional realm and had him examining and processing some of that information. At the end, he said, I wouldn't be surprised if I never drank again. He finished the study, did not have a drink. We saw him, he checks in, from time to time, he'll come in, and he's completely sober. Completely sober. So he said that this was the most spiritually significant experience of his life, and he maintained that relationship to his connection to Source through a variety of different practices, independent of us. We don't push the spiritual side of things. We kind of let people just have their own experience, and whatever it is, we support it. So this is kind of coming of his own volition, which is remarkable. So the next case is very different. These cases are selected, to illustrate the variety of experiences that people can have. It's not all bliss and unity. There's some heaviness to it too. So, these are selected to showcase that. So the next person, we'll call him Paul, was a 52-year-old man who was unemployed for a year prior to the trial. And he said that, He said that he had been drinking since college and had a lot of guilt and anger over his relationship to alcohol, though was obviously still drinking. Alcohol cut his academic career short. It cut his athletic career short. He was on track to be a very successful, college basketball player. His social life and his family, they were so linked with alcohol. The family all drank, didn't really talk about it as being an issue. There was actually pressure to drink that was present, so someone not drinking was very unusual for the members of the family. And his dad actually had died of alcohol complications, so strong family history that ended in death there. So he had not had any treatment history when he came to us. At intake, he was drinking almost daily, around 4 drinks per drinking day. So he had tried mescaline twice in a recreational high school, from the sounds of it, a lower dose setting back maybe 30 years ago. Oops, there's the preview. So I'll go through his, actually, you've already seen it, so I'll tell you. It was a tough one. So during his first medication session, he only opted for one. He, very early on into the session, he perceived his father to be present, and he started communicating with his deceased father and said that he reached a point of resolution. But another thing to note about this person is that he was a devout Muslim and said that it was in conflict with his faith tradition to communicate with the deceased. And so that came up very strongly during the session, right after or during his communion with his dad. And so at that point, he started to feel this sense of unease with taking this medication, with the fact that he was communicating with his dad, and he decided to resist the medication for the remainder of the session. So he ended up experiencing a lot of abdominal pain and was, clutching his abdomen for hours during that dosing day. And at one point, he was actually started to do like a dry heave process, which lasted for a while. So he said when he reflected on that he was perceiving alcohol purging out of his system. And then he started to spit. He started to spit out anger. He started to spit out resentment. He started to spit out shame, all of the things that he had been carrying that were associated with his drinking. So around 4 hours after the peak intensity point, he was just so exhausted from doing this for hours that he kind of relaxed and allowed himself to rest and to stop resisting. And at that point, allowed the medication to kind of bring him back. But for the more intense portion of this, he was fighting it with all of his will. And he said nothing ever felt worse than those 2 hours. And he still said that at the end of the study. He said that was the worst thing I've ever experienced. But after that first dosing session, he did not touch alcohol again. He stopped drinking. And he said that he was actually proud of the capacity of his will to resist the intensity of the medication. So beautiful narratives are emerging, even when it's not, what you would traditionally think of as being a particularly beautiful experience. So there's value to having whatever experience comes up. And this person is just a perfect example of that. An interesting thing about him, so he went back after this study. He went to study social work to become an addictions counselor, which is cool. They're amazing. So the third case is Mary. So she's a 52-year-old female healthcare provider. And so she had 3 medication sessions. So when she started with us, she had a lot of anxiety and depression, had a lot of concerns about the physical impact of drinking on her system, drank in isolation, so had this sense of, the theme of being disconnected was fairly strong with her, lots of guilt and shame, very, very strong negative self-talk, so that inner critic was very, very strong and present and hard to control. At intake, 67 out of 84 drinking days, average of 3 drinks per drinking day, so not one of our heavier ones, but had a long history of, having some difficult experiences, had a very difficult childhood in relation to her mother. So In her first medication session, this was a low-intensity experience that was covering a lot of autobiographical information, childhood reflections, memories, etc., and no previous psychedelic use for her. So the second session is really the one where she had the most to say. So I'm focusing on the ones where these individuals are having the most to share. So the second session for her was one of higher intensity, and said that she had experienced the sense of overwhelming love pouring through her. That was, prior to that session, something that she had not been able to access. So love for herself, love for others, just love in general was very challenging to access for her. And there's quotes here that are actually snippets from a conversation that she said she was having with God. That was the language that she used, so I'll use it. So she said to God, why did you leave me? Because she was very connected spiritually in her childhood, and then in her adulthood felt a sense of separation. And she heard a voice come in and say, why are you so controlling? And then that voice said, I'm going to tell you a secret, and it's the worst kept secret in the universe because everyone knows it to be true but you. And it said, you're a perfect creation of the universe. And so she said her immediate response was to come up with reasons as to why that wasn't true. And so she would raise all of her reasons as to why that wasn't true, and the voice would repeat it again. You're a perfect creation of the universe. And she would have more information as to why she wasn't, and that voice would come back and say it again. So she said that voice repeated that statement to the point where she had exhausted all of the reasons as to why she wasn't a perfect creation of the universe. And so when she discarded all of that, she said that she, for the first time, was able to take that truth in and experience it fully through her system. So she said after that session, the noise can bubble up, it doesn't overwhelm me. There was a sense of being safe in existence, being supported, being at peace, being supported in her body. The interesting thing with her is that her regular drinking stopped, but she was still drinking. She said she would have a glass of wine with friends on occasion. So not complete abstinence like the last two participants that I showed. Different style of drinking, different relationship to drinking, but she said that it wasn't an issue for her. She could have one glass or two of wine and she could stop. That compulsion to continue didn't exist. And interestingly, that negative self-talk, she said that inner critic that had been with her, she felt that leave. So we didn't see her after her week 12 or the follow-ups for a long period. And then she came back and she opted into that third dosing session. And in that period, she had one drinking relapse, which was on the night of the election. And I know this is what we're dealing with in America, guys. So when Trump was elected, that was very challenging for her. And she drank a lot that night. It was just once. And I mean, it's interesting, a lot of the therapy sessions involve a discussion about the political situation in the States right now. So she had taken in a lot of anxiety over this political process. When she came back for that third session, she said, I want to be free from this anxiety, and had a session that was a complete discharge of anxiety. So non-specific, similar to the first patient that I talked about. 3 to 4 hours of the worst anxiety she's ever experienced in her life, not tied to narrative, and then afterwards said, that is gone, I feel lighter and I don't feel anxious anymore. So she actually, at the end of the study, she said that she had a desire, to get involved with politics and to start using the gifts that she has professionally and personally to help inspire others to get involved in local politics. So we're seeing this, this theme of doing something at a greater level. The few participants that are actually in the study right now, I'd love to just highlight because there's some interesting observations that we're seeing with them that would be worth sharing. So this person is currently in the trial. She's 41, is a teacher, had a strong background in spiritual practices. So this person spent time living in an ashram in India, had done extensive practices through a number of different traditions, had done Kundalini yoga. It just was very familiar with altering consciousness and had the ability to do that without any sort of psychedelics. So what's interesting about her case is in the first 2 sessions, she had a familiar experience of communion with the divine. She was experiencing rapture, heart opening, very transcendent aspects to this experience. But her body, one thing that we noticed is that her body was having profound energetic movements, especially during the earlier part of the session. So there was movements like a shaking through her central channel. And so I'm using her terminology here, she said that was Kundalini energy moving through her body, but it was very, very visceral, very apparent to the observers in the room, which is something just to note that it's coming up. It's coming up for other participants too, whether that's a release, of trauma, shaking can happen, whether it is energetic systems being opened or activated through this medicine. It's possible. We're unsure right now, but the interesting thing about her and this theme of the system and each individual knowing what's right for their healing process is that though she had such a transcendent, as she described it, experience, all of the lessons that she received were related to grounding, so to being in body-based awareness. So she came back and her integration process was about how do I connect to the body? How do I connect to nutrition, self-love? How do I set boundaries in relationships? So letting that inner narrator. Last minute? Okay. All right, so I'll go quickly through the last two because they're all interesting, guys. It's hard. So this next person is, he's in the study, just finished up actually, had 2 sessions that were profoundly transcendent in terms of his qualitative experience, and he walked into his 3rd dosing session sure that he was going to just shoot right into unity and bliss, and had this major expectation of moving into that space. And that was not what happened. So it's really interesting that this person was exposed to the shadow aspects of himself. So again, we get that theme of the system knowing exactly what's right for each person's individual journey. So the theme around this person's journey was about integrating the light and the dark, not passing through the darkness and disregarding it and focusing only on the transcendent, blissful experiences. Last person is with us now, just had his dosing session last week. So in Med 1, he was communicating with what he described to be guides on his session who took him, we were basically providing insight to him, providing him with lessons at a cosmic level. So not autobiographical information, but really about humanity and existence, evolution, etc. And so the message from Med Session 1 was that everything that's happening in the session is actually coming from within you. So all of the answers that you're seeking are within you. It's a lesson in sufficiency, complete sufficiency, and confidence within the self. And so his second medication session is noteworthy because as a team, we tend to orient people to surrender, to letting go, to going with the experience. But this person actually took a movement in a different direction, which is interesting. So they listened to their inner authority. They resisted what the surrender aspect because they knew what was right for them. So part of this healing process is amplifying the voice that's within so that each person can unfold in the way that they need to. How am I doing for time?
You're pretty much done.
I'm pretty much done. Okay, sorry folks. There's just more, Okay, well that covers it. Yeah, I think we're good. Thank you so much for being here.